Hello all and welcome to this online presentation on critically appraising systematic reviews. So in this presentation we'll briefly discuss exactly what is a systematic review. We'll discuss sources of bias around systematic reviews. More importantly, we'll focus on how to read or interpret a forest plot. And then we'll finish off by showing a couple of examples around specific analyses that can be done in systematic reviews. So what is the difference between a systematic and narrative review? And we can just look towards the name itself to identify the differences between the two. So a narrative review is just another word for your standard literature review. So normal narrative or standard literature reviews predominantly lack any rigour, and if you can think of going back over your careers, anytime you've needed written a literature review, you've probably gone out, identified a few papers that support your stance, and used them as your literature review. So usually these reviews are broad in scope. Usually you just identify papers that are going to support your viewpoint, don't have any critical appraisal aspects associated with it, and it's really just a broad summary of the papers that you have identified. Systematic reviews, on the other hand, hopefully are more rigorous in order to minimise bias. So they're specifically structured so that if you really wanted to, you could replicate that systematic review and you would get the same answer. So each systematic review has a specific PICO question. If it's a Cochrane review, then there will be a protocol published in which the authors have previously published the methodology of the review. There will be a comprehensive search strategy, so a literal search strategy in terms of the PICO components. Databases searched will be identified. There will be a set critical appraisal in terms of the quality of the papers included in the study. There will be a descriptive summary of the data, and if appropriate, there will also be a meta-analysis conducted as well. So you would think if we're conducting a systematic review that it should be free of bias. Unfortunately not. There are a number of ways in which bias can still creep in even when you're doing a systematic review, whether it be the inclusion criteria, so you only look at specific types of studies that are included, whether your literature search is not broad enough, so it's not feasible just to do a search of Medline. A number of databases have to be searched, whether or not there is being publication bias within the discipline itself, and the actual assessment or critical appraisal of the studies, whether or not that has been done sufficiently as well. So here are a couple of examples in which we can identify whether or not publication bias has been a factor within the study. So typically, if we look at all of the studies that have been published on a particular topic, we would get the majority of studies sort of grouped along the same plane. So let's say we're looking at the odds ratios of a particular intervention and outcome. Across here we've got the standard error. So basically another way to look at this is the higher up here, the larger the sample size for the particular study. So we might have RCTs that have got 10,000 patients up here, as opposed to studies that have got 50 patients down here. So basically we're looking at the precision of the studies here, and then we're looking at the odds ratios. So when we're looking at publication bias, what we should hopefully be able to identify are small and large studies on a particular topic, but also studies that report both a positive and a negative outcome, and sometimes even no outcome whatsoever as well. So in this case, we can identify that we've got quite a bit of large studies up this area of the graph. And all of these studies seem to report a similar sort of odds ratio, about 0.5 or thereabouts. What we then also have are these negative well, in this case, we'll call it positive studies. So positive studies in the sense that the odds ratio, if we're looking at from an intervention point of view, is much more significant than these studies here. So same sort of thing. We've got quite a few smaller studies, and we've got a couple of larger studies, but we're still seeing that same sort of grouping. Then if we flip it over on this side, again we've got a couple of studies up here that are larger and a couple of these smaller studies that report a more extreme outcome measure. So this is typically what we'd see in terms of a funnel plot, and this would represent no publication bias. So if we were to do a literature search on Medline, we're going to get, or we're going to identify the majority of studies that have been published in this area along here. We'll also get these smaller studies, both reporting a negative and positive outcome. Conversely, if we look at this graph here, in this particular literature search, we've only been able to identify the few bigger RCTs that have reported the same sort of study, and we've also only been able to report those other studies which have reported a beneficial outcome or event rate. We're missing these particular studies, and it might only be one or two down here, but there should be some sort of studies out here which are reporting the opposite effect. In this case, we're seeing what we call publication bias through the representation of this funnel. So in terms of measuring outcomes in systematic reviews, once again, for dichotomous outcomes, the majority of systematic reviews and the meta-analysis will report it as a relative risk. Some may report it as an odds ratio, and even fewer will report it as an absolute risk reduction or number needed to treat. Majority of times it's reported as relative risk, and we'll run through a couple of those examples. For continuous outcomes, there's only really two outcomes, two methods or two measures in which they can be reported. The first being weighted mean difference. So that's when the outcome of interest is measured on the same scale. So something like blood pressure. You can have 15 different types of RCTs, and they'll all measure blood pressure on the exact same scale. Standardized mean difference is when the outcome, that being a continuous outcome, is conceptually the same but can be measured across different scales. So something like quality of life or pain or depression or whatever it may be. One study might measure, let's say, pain on a scale of 0 to 5, so 0 being no pain, 5 being significant pain. Another study may measure pain on a scale of 0 to 100, so 0 being no pain, 100 being severe pain. So standardized mean difference takes the exact same continuous outcome, which is conceptually the same, and then is able to standardize it according to one particular scale. So what we want to do now is just ensure that everyone understands how to read a forest plot, and we'll run through that across this slide. So in this case we're using the review for colorectal cancer using the FOBT. So our comparison is the FOBT versus control, and our outcome being colorectal cancer mortality. So for each forest plot we'll have the studies that have been included in this meta-analysis. So in this case we've got 1, 2, 3, 4 studies, and they've all been named a particular identifier, and they will all have their outcomes allocated to the screening group, or in this case screening intervention group versus the control group. So for example, if we look at the first study, Funan, we can see that 30,967 participants were allocated to the intervention group, that is the screening group, of which 362 died. Comparing that to the control group, which had 30,966 participants allocated to it, of which 431 died. And then we can run through the others and we get the same result. Second aspect of the forest plot that we want to identify, I guess, are these blobs. So blobs, and that's the technical term. You can identify it through graphically through the blobs themselves, or through this illustrative example here. So when we're doing a meta-analysis, we're not just clumping all of the individual trials together. That would be wrong, because we'd be losing the integrity of the meta-analysis itself. What a meta-analysis does is that it takes into account the various contributions of each of these studies from a sample size perspective. So for example, if you look at this Nottingham study, we can identify that each group has over 76,000 participants allocated to it. So if you look at the amount to which that study contributes to the overall meta-analysis, it's going to be higher than, let's say, the Minnesota study, which only has 15,000 odd participants allocated to it. So this particular Nottingham study will contribute 42% of the overall meta-analysis, as opposed to these smaller studies of Minnesota, Gothenburg and Funen. And generally speaking, the larger the blob, the greater the contribution to the overall meta-analysis itself. And then finally, interpreting, I guess, the meta-analysis itself. So in this case, the authors have decided to use the odds ratio. We're looking at the effectiveness of screening versus not screening with the FOBT in terms of reducing colorectal cancer mortality. So again, we can look at the trials individually, whether it be graphically or from this point of view over here statistically. So if we look at this graphically, we can see that the odds ratio is less than 1. The confidence intervals are fairly hard to make out, but nonetheless we can identify that this upper confidence interval doesn't include 1. So it's statistically significant. We can always look at it through the statistical point of view. So in this case, for our Funen study, the odds ratio is 0.84, and we can see that the confidence intervals are 0.73 to 0.96. So in this case, the Funen study is reporting that the FOBT significantly reduces the risk of colorectal cancer, and that difference is statistically significant. And we can run through all the other individual trials as well, and we get a similar result. Finally, the meta-analysis is this overall number down here. Again, you can look at it graphically, and the reason why we have this diamond point is just to differentiate that this is the meta-analysis as opposed to the individual trials. And looking at the overall meta-analysis, the odds ratio is 0.84. With the confidence interval of 0.78 to 0.90. So overall, these studies, when you combine them together in a meta-analysis, identified that the FOBT is statistically significant in terms of reducing colorectal cancer mortality when comparing it to no screening. So this slide is a similar slide, the only difference being that we're looking at a continuous outcome. So in this case, we're looking at glucosamine therapy for treating osteoarthritis. We're looking at glucosamine versus NSAIDs, and the outcome being pain. So once again, we've got our studies listed down here. The only difference being in outcomes that are looking at continuous outcomes, the meta-analysis will be reported as the number of participants and the mean and standard deviation per each group. So 317 participants in the glucosamine arm as opposed to 318 participants in the NSAIDs arm, 87 participants in the glucosamine, 81 participants in the NSAIDs, etc., etc. Same sort of principle applies. In this case, our first study seems to be favouring our NSAIDs as they are the comparison. So the pain seems to be less when we're looking at our NSAIDs. And I guess the thing to note is anytime we're looking at an outcome of mean difference, unlike relative risk, where if we have a relative risk of 1, it indicates no difference. With mean difference, if we have a mean difference of 0, then it obviously indicates no difference between the two groups itself. And I guess an interesting thing to note with this particular meta-analysis, the first study is reporting that the NSAIDs are more beneficial, although the confidence interval is overlapping 0, so we wouldn't say that it is statistically significant. But the remaining 3 studies report that a benefit in terms of glucosamine reducing pain. Interesting for the fact that when you combine them in the overall meta-analysis, it would indicate that the glucosamine, or that there is a trend for glucosamine to more effectively reduce pain compared to NSAIDs. But when we look at the confidence intervals, because it includes 0, we can't say that there is any statistical difference between the two groups. So briefly, I just want to mention statistical heterogeneity. So the one thing about doing a meta-analysis is it's great to combine the studies and the data from the studies to get a larger sample size, so to speak. However, if we have this thing called statistical heterogeneity, that is, there is significant variation between the studies in terms of their properties, then it rules out the necessity to do a meta-analysis. So it's basically saying if our studies are so different from one another, what's the point in doing a meta-analysis in the first place? So there's a number of ways in which we can identify whether or not our studies are heterogeneous. So in this case, we don't want any heterogeneity between our studies. We want our studies to be homogeneous, that is, as similar as possible, because that ensures that we can then do a meta-analysis. We'll, like I mentioned, there's a couple of ways in which we can identify heterogeneity and whether it's present. The first is to look at the chi-square test, which I'll demonstrate in the next slide, and there's also a couple other variations which we'll demonstrate. So if we look at the various tests to identify heterogeneity, they're usually reported down the bottom here. We can see that our chi-squared is 1.65, which is great, and it means absolutely nothing to most people. If we look at the degrees of freedom, we can see that it's 3. Great. Again, it's not going to really mean a whole lot to a whole lot of people. The thing that you can identify here are these last 2 elements. So if our p-value in this case is greater than 0.05, this indicates that there is no heterogeneity between our results. There is no heterogeneity between our studies, therefore it is valid to do a meta-analysis. So it's sort of, I guess, counterintuitive to what we usually preach, in the sense that we want our p-value to be greater than 0.05. That is, we don't want to see significant difference between the groups. If we had a p-value of 0.05 or less, it would indicate heterogeneity, which would indicate that our meta-analysis is flawed and there's no real reason to do a meta-analysis. Conversely, we can look at this I-squared statistic. If our I-squared statistic is reporting 0, this is a great thing. It's reporting 0 heterogeneity. The closer we get to 100%, the worse it is in terms of the heterogeneity. So basically, a ballpark figure, if we've got an I-squared of 0, great, 50%, moderate heterogeneity, anything above 50% is questioning whether or not we should be doing a meta-analysis in the first place. So the last couple of slides, I just wanted to mention and give a couple of examples on sensitivity and subgroup analysis. So sensitivity analysis we can do if we've identified that we've got studies that vary in their quality. So if you can recall at the start of the presentation, we reported that systematic reviews critically appraise each of the studies that are included in the review itself. So within the review we might appraise 10 studies and 5 may be deemed to be good quality and the remaining 5 may be poor quality. What a sensitivity analysis allows us to do is to do a meta-analysis with all of those studies included and then reanalyze them according to whether they are good quality or bad quality and see whether or not that makes a difference on the overall outcome. Finally, subgroup analysis, as the name suggests, just allows you to perform the same sort of critical appraisal and meta-analysis according to different subgroups. So whether it be age, sex, drug doses, duration, whatever it may be. So this is an example of sensitivity analysis. In this particular review, we're looking again at glucosamine for treatment of osteoarthritis. We've got glucosamine versus placebo. Our outcome is pain, and in this case we've got all of the particular studies that were included in the review, or should I say identified in the review. If we look at the overall meta-analysis down here, we've got a standardised mean difference of negative 0.47 on this pain scale. The thing to note is that the confidence intervals don't include 0, so it would suggest that glucosamine is significantly better than placebo at reducing pain. Great. Let's have a look at a sensitivity analysis then when we exclude the bad quality studies. So in this example, same meta-analysis, the only difference is we've excluded the poor quality studies. So rather than having that huge number of studies, we've significantly reduced it. Again, if we perform a meta-analysis on it, similar sort of result in the sense that we get a trend that indicates that glucosamine may be beneficial. However, if we look at the actual confidence interval, in this case, it includes 0. So we can't statistically say that there is a significant difference between glucosamine and placebo. So it sort of leaves the reviewers to ponder whether or not they should base their recommendations on the good quality studies that are available, which indicate that glucosamine basically is not effective, or whether they should recommend or base their recommendations on all of the studies, including the poor studies, which would indicate that glucosamine is beneficial. Why they are poor? Well, I guess I'll let you to reflect on why they may have been assessed as being poor. Finally, subgroup analysis. So again, same sort of principles apply. We're using our glucosamine for treating osteoarthritis example here. In this particular subgroup analysis, we're looking at different types of preparation of glucosamine. So in this example, we're looking at a rotter preparation. We're measuring pain in terms of the outcome. If we look at the overall result here, the standardised mean difference is minus 1.1 in terms of pain. The confidence intervals don't include 1, so it would suggest that this rotter preparation of glucosamine is significantly better at reducing pain than placebo, and it's statistically different as well. If we look in this example at a subgroup in which we're looking at a non-rotter preparation of glucosamine, performing a meta-analysis, once again we can see that there seems to be a slight trend in terms of glucosamine being beneficial, but in terms of the confidence intervals, they include 0. So what we can conclude from this is that the rotter preparation of glucosamine is significantly better at reducing pain compared to the non-rotter preparation of glucosamine. That's all for now, folks. As they say in the classics, thank you very much for your time, and as always, please feel free to email me if you've got any comments. Cheers.